Great, thank you very much, Anka. So I'm a GP in Surrey and do 7 sessions a week. I work closely with Jude Hayward, who's a GP in Yorkshire, who's a GP with a specialist interest in genetics. I think she's probably the only one. She works within the Yorkshire Genetics Service. And we've known each other since about 2005, when the genetics white paper came out, telling us about the genetics revolution. And I think somehow now it feels very different, and I'll just go through why. I'm also pleased that we said primary care and not general practice, because I completely agree that this is going to be a wide primary care initiative, not just focused in on general practice. So what I thought I would do is just go through an implementation checklist as to how pertinent pharmacogenomics might be in practice and some of the issues that might occur that we would need to go through to implement. And we've heard a lot about implementation already through the NHS, so I think you've probably gathered all the main essential points, really. But this implementation checklist came from Future Health Journal, and I found it quite useful. But I think the first thing to say is about the environment. So we're clearly going through major change in terms of infrastructure, in terms of the offering of genetic testing, in terms of access to testing, but also the role of HEE in terms of thinking around mainstreaming genomic testing. The Academy of Royal Medical Colleges are looking closely at clinical pathways as well as an educational subgroup. So there's lots of activity going on, as you've heard this morning. So these are sort of just like random guesses, slightly random guesses as to how change may what changes we might see relevant to genomic medicine over the ensuing years. And clearly the important thing at the moment is to pick up on genomic literacy and understand what genomics means for practice. And everything else will follow suit. The other really important point, I think, is around patient ownership of the data and consumerism. So increasingly patients will have the opportunity to as we've heard, buy over-the-counter genetic information. And how we manage that through the NHS is going to be a bit of a challenge, I think. The other thing about environment also in general practice is to consider the work issues, the work challenges, and the lack of general practitioners due to early retirement or not coming through training. And this map through NHS Digital just tells us a map around the UK of where there are deficits in the provision of general practice services. So the darker the area, the more patients there are per GP in that area. And I think this is really important in terms of patient access to genomic testing and genomic treatments. The RCGP are very focused in on recruitment and what they can do to try and stimulate general practice. And they come up with this action plan, the 2022 GP action plan, which really extols the virtues of general practice. So we must think about general practice being a very generalist care approach, but we're also very much interested in delivering personalised care. We need to increase the capacity of the workforce. We need to develop new skills and be also flexible to changes in the way that we practice medicine. And this includes new models of care that might be incorporated through practice. And the importance also of maintaining an academic activity in practice, I think, is really important. So what about the evidence that's being made for implementation for pharmacogenomics? Well, we've heard about whole genome sequencing and the data flows, and after analysis, the increasing databases that are being set out to store all this information that's coming through, so that we end up with lists of pathogenic variants that might be helpful in terms of managing patients. But the accrual of data is not just localized to the United Kingdom. So the Dutch Pharmacogenomics working groups have published many guidelines. Clinical Pharmacogenomics Implementation Consortia, which is based in USA. Again, lots of good guidelines around gene variants. We've got the FDA labeling of drugs, which advises when genetic testing should be done, but whether it's done or not is another thing. Phil Evans from the NIHR Clinical Research Network, which includes primary care, has also led on a piece of work that looked at genomic research in primary care. So there's lots of evidence that's coming through about the sort of genomic variants we might use in pharmacogenomics. We also heard lots this morning about targeted therapies, and so this might apply, for example, to warfarin, where we have a person or a homogeneous population at risk, which are given an intervention, which may be genomic testing, which then leads to prevention of an adverse effect, and we know the number of emergencies due to adverse drug reactions, is a significant problem. But general practice isn't really like this in real life. The population at risk may be much bigger. There are many more factors that could influence care and influence response to treatment, so that your intervention and then reduction in adverse effects is actually going to be much less. So I think the targeted approach, I think, is going to be really important. But we need to be mindful of this great big population. How do we offer genomic testing to this population at risk? And this population at risk can be defined, for example, by multimorbidity and polypharmacy. So we have many patients who have more than 2 linked conditions. They can have significant conditions like diabetes, coronary heart disease, atrial fibrillation, and so on. Patients may be on more than 10 individual drugs, and for each of these conditions, there are evidence-based drug prescribing, which adds to complexity. And then how we manage multimorbidity in clinical practice has obviously been researched, but to date, it's been mixed effects as to what is the most effective way of managing patients with multimorbidity. So going down the checklist, the next is looking at models of care that we might want to consider around implementing pharmacogenomics in practice. And there's an example, for example, in the US, at Vanderbilt, where they're looking at proactive genotyping to support and using the electronic health record to support pharmacogenomic testing. In terms of primary care, we heard a little bit this morning about the role of pharmacists, and I think Meneer mentioned the Dutch system where they have a genetic card, and the pharmacists help to advise the population on genetic risk. But in primary care, there has been a study which has looked at pharmacogenomic testing with clinical decision support system, and the research around that continues, but I'll mention that in a second. Before I do, I just want to tell you about context and the way we work. So this is Jude's office, and if you take away Jude from the slide, you'll see a chair and you'll see a computer. The chair may actually belong not only to the GP, but also to the in-practice pharmacists, to practice nurses, maybe even to paramedics. So increasingly, there's multidisciplinary members within general practice who are working together in general practice. The other thing that dominates this picture also is the computer, and we have this sort of relationship between the doctor, the patient, and the computer usually dominates. But we should be able to use the computer to our advantage in terms of making decisions around pharmacogenomics and prescribing. This is my desk, which is very similar to Jude's. I just wanted to show you my Spider-Man mug and my short bed diskette bin at the back there. But the computer again dominates the picture. So here, this slide is telling us about family history, and I'm not going to go into the specifics of this, other to say that there's lots of information that needs to be recorded on the care record, on the patient record, which then needs to be searchable and easily accessible so that we use it in terms of making decisions around clinical care. And so in this case, for example, how do we record family history in a meaningful way? Because we certainly can't draw pedigrees on our current systems at the moment. So we may have templates like this, and this is something called Q-risk, which helps to work out cardiovascular risk. And over time, we will have a combination of data which takes into account phenotype as well as genomic data, which then together, hopefully, will be able to enable us to manage our patients effectively. So going back to the model I mentioned about pharmacogenomic testing in primary care, there's this company called Genomics, which is based in British Columbia, which has a lead GP called Martin Dawes. And they've looked at the common conditions presenting in primary care, and then looked at drug prescribing and looked at gene variants associated with those drugs. So they've come up with a decision support system that enables the use of genomic information in terms of drug prescribing. So what they've done is that they did this feasibility study. They looked at actionable pharmacogenomic testing, and their primary outcome was to try and obtain genotypic samples from patients, which they did very well. They also wanted to see whether they could use that information to link it with decision support software, which would then help in terms of drug prescribing. And they tested 189 patients, and they found 96% of samples had at least one actionable genotype, which we've heard about this morning. And this is the sort of report that might come out of a system like this, where in this instance you're looking at clopidogrel and you come up with a phenotype, and the clinical device here is that there's a reduced response to clopidogrel for this particular patient. And so there's an actionable decision to be made about whether to consider alternative therapies. So it's a useful clinical decision support system, but the limitation with the system is that it's not integrated with the electronic care health record. And I think that's really important. I think for it to work in clinical practice, I think there needs to be this marriage to enable clinical use. So to get buy-in, it's going to be much greater value if we use clinical decision support systems like that are relevant to practice, that integrate with the GPI system, that fits in with workloads and work patterns, as well as fitting in, obviously, with the priorities of the NHS, and we've heard all about that this morning. Clearly, there needs to be an evidence base. But for GPs to use this system, or any other multidisciplinary team member to use this system, there needs to be outcome measures, and in this case, around prescribing, effects on consultation rates and prescribing decisions. So in practice, we do lots of repeat prescribing work and here I'm quoting 200 repeat prescriptions for each GP. We also have more patients that we look after compared with most European countries in a working day. And many of these patients have long-term conditions with multiple drugs. So if we can use pharmacogenomic prescribing results, which can then help in terms of patient adherence and reduce adverse drug reactions, then I think that will be well received. There has been quite a lot of work done already around prescribing safely, and I won't go through all the slides, but other than to say the more drugs you prescribe, the greater chance there is of drug errors. And also the combination of drugs you use, again, could lead to greater chance of adverse effects, such as non-steroidal anti-inflammatories without gastric protection cover, for example. So the genomic testing database that we heard from Sue Hill is going to be the mechanism in which, in clinical practice, we can use testing that's available through the NHS, for example, in general practice. And clearly this will all be around, having the lab accreditation in place, having it as part of normal NHS activity, handling samples efficiently and also in a timely manner as well. But if we're going to use all this information in practice, we also need to resource the time that we need to give in clinical practice. So currently in general practice, we on average have 10 minutes per patient, which really isn't going to be long enough if we're going to have these complex decisions about prescribing based on genomic data. Hopefully the genomic testing database will tell us when to test, it will tell us who we're going to do the test on, what tests to use, what the clinical utility be, and what the evidence base will be. And again, in primary care, you're going to have lots of inquiries about why we're doing this test and the background to it. There are also lots of changes happening in primary care as well in terms of how services are delivered. And so increasingly you'll hear about things like primary care networks, which are practices coming together in a locality. You're hearing about federations of practices, which are multiple practices, again, working together. You might even hear about super practices, which cover practice populations of over 200,000 patients. So there are going to be very different models of general practice and primary care, and how we can use those models in terms of delivering pharmacogenomics, I think, will be interesting. The other thing is about clinical leadership as well. And the RCGP very much support innovation and forward thinking, I think. And they recognize where genomics sits and the importance of genomics and working with the NHS to help deliver a genomic-based service. And with that in mind, there have been papers that have been put through RCGP Council, which have debated and analysed and looked at what the potential impact of genomics might be in practice, as well as considering the ethics of genomics as well. And soon, hopefully within the next month, and with the support of HEE, we will have a genomics toolkit up on the RCGP website, which will give you some background to genomics and how it might be applied to primary care. The other aspect of this is also not working in isolation or not working in silos, which increasingly happens in clinical practice. And I think if we're talking about mainstreaming genomics, there does need to be this integrated approach between primary and secondary care so that we learn off each other. And we're trying to do a project with St. George's, for example, led by Muriel. But I think it's really important that we take this sort of approach, really, because there are going to be many people, both in primary and secondary care, who are not going to be genomic experts, who are going to be genomic literate. HEE are obviously working on the education and training aspects of genomics and helping to deliver that. In terms of general practice, we have the membership of the Royal College of General Practitioners. And to get to that level requires some new trainees coming through, working with their trainers, but also sitting the exam as well. One of the bottlenecks, though, is the fact that we don't have many trainers who are versed around genomics. The new curriculum for the college exam is looking at and taking a very genomic perspective, but that's yet to be ratified by the GMC. And then finally, I think the important thing is having time, in terms of not only being able to talk with our patients about what genomic testing might mean, but also making sure that we get results back in a timely way, so that we have patients who hopefully will be able to adhere to the medicines because they're not getting adverse drug reactions, that they get benefits, but we also are able to measure outcomes and what effect this genomic testing in practice might actually have. So we're very much in practice looking to see if we can facilitate the adoption and diffusion of this new knowledge in clinical practice. Clearly there's going to be lots of work that needs to be done around mainstreaming genomics and genomic knowledge. We must be mindful of models of care and how they may impact on the way that we deliver services. And let's work together through an integrated approach. I think I'll stop there. Thank you.